So we are now thinking about another form of presentation of chronic obstructive pulmonary disease, and that is emphysema. Now, emphysema describes loss of elasticity in the alveoli with permanent enlargement of the air spaces. So in a healthy lung, there's going to be untold millions of very small alveoli, so that gives a large internal surface area. It's been estimated that in a young, healthy lung, there's about 140 square metres of alveolar surface area available for gaseous exchange, something like 70 square metres in each lung. But with loss of the alveoli, the air spaces are going to become bigger, and that means there is less internal surface area over which gaseous exchange can take place. And a healthy alveoli is normally very elastic as well. So when you inspire, it's blown up. And then when the person stops breathing in and it's time to breathe out, the alveoli will naturally contract like a balloon. They have elastic walls, and this will blow the air out of the lungs. So in emphysema, there's loss of this elasticity, there's loss of the alveolar walls, and therefore there is a permanent enlargement of the air spaces. That's what goes wrong. Right, what causes this condition? Well, no surprise again, the main cause is smoke. Smoke getting into the alveoli. So people inhale smoke, whether it's from cigarettes or chronic exposure to wood smoke or whatever it is, and the little tiny smoke particles get right down into the alveoli. And of course they're not supposed to be there, so they cause an inflammatory reaction. The presence of the smoke particles in the alveoli causes inflammation. And inflammatory cells are therefore attracted to the area, such as neutrophils and monocytes. And in people that smoke, there's going to be more of these white blood cells present in the alveoli. Now, under normal circumstances, this is good because the neutrophils and the monocytes are phagocytic. They are eating cells. So, for example, if it was bacteria that got into the alveoli, then the macrophages and the neutrophils would gobble them all up. They would be ingested by the process of phagocytosis, and they would be digested, and therefore the bacteria and any potential threat would be removed from the alveoli. So normally it's good that the white cells are there. But when the white cells phagocytose the smoke particles, they can't digest them, because the digestive enzymes they produce are designed to digest proteins and fats and carbohydrates in bacteria and viruses. They're not designed to digest smoke particles. So if you like, these white blood cells get a bit of indigestion. They can't digest the smoke particles. And what this means is that the digestive enzymes from the lysosomes of the neutrophils and the monocytes actually start to leak out of the cells. So you get proteases, collagenases and elastases released into the alveoli. Now, a protease is any enzyme which will digest protein. A collagenase is an enzyme which will digest collagen, which is of course a main structural protein. An elastase is a digestive enzyme which will digest elastic tissue, which of course is essential to give the alveoli their elasticity. So because these digestive enzymes leak out into the alveoli, it means the cell walls of the alveoli are digested. That's what gives rise to the permanent enlargement of the air spaces. The walls are physically digested. And also because the elastase breaks down the elastic tissue, the elasticity is lost. So this is explaining why emphysema is loss of elasticity in the alveoli with permanent enlargement of the air spaces. That's what it is. And this means there's a loss of respiratory surface area. There's a loss of elasticity. So as expiration begins, there's a reduced air pressure because the alveolar walls are not contracting down to increase the air pressure. The normal elastic recoil of the alveoli is going to be lost. So there's no air blowing out into the small airways, into the bronchioles, and this allows the bronchioles to collapse. And as well as that, because there's other hyperinflated alveoli in the area, they're hyperinflated because there's no elasticity, the air's not blown out, so you get hyperinflated alveoli. And adjacent hyperinflated alveoli are going to impinge on neighbouring bronchial passages, pushing them shut. So the patient's going to find it difficult to breathe out, firstly because they've lost the elasticity from the alveoli, and secondly because the bronchial passages are going to collapse and going to be shut by the adjacent hyperinflated alveoli. Now I know that might be a bit hard to visualise on the podcast, but if you've got the Black Pathophysiology book, this is clearly illustrated on page 213 if you want to turn to that. So, we've got collapsed bronchial passages. This means the patient can't breathe out. There's going to be airway obstruction because the bronchial passages are collapsed. Now, there was airway obstruction in chronic bronchitis because of the presence of the mucus, the enlarged submucosa, the edema, and in the smaller airways the fibrosis. That's what caused the obstruction in chronic bronchitis. But there's also obstruction in emphysema caused by this collapse of the bronchioles. So it's still a chronic obstructive pulmonary disease, and it leads to lung hyperinflation. The lungs are overblown up with air that they can't breathe out effectively. So what clinical features are we going to see? Well, in emphysema, the patient tries to compensate for the increase in carbon dioxide and the lack of oxygen in their blood. They are described as fighters. They will breathe faster to try and compensate. So yes, there's less oxygen getting into the blood every time they breathe in, and there's less carbon dioxide getting out. So they breathe harder and faster to compensate. They're described as puffing patients. They breathe faster, they breathe harder to try and compensate for the deficiency in lung function. And because they breathe harder and breathe faster, they're able to maintain their oxygen levels so they don't go blue like bronchitic patients. They can remain pink. So these patients are sometimes described as pink puffers. They are pink and puffing because there is increased respiratory effort to compensate. So they are fighters, and they do experience dyspnea at rest, unlike patients with chronic bronchitis, who tend only to experience it with exercise. But because the levels of carbon dioxide in the blood are kept relatively normal, the hypercarbic drive is preserved, and these patients don't retain large amounts of carbon dioxide like the pure chronic bronchitis patient does. And because they have difficulty breathing out, what these patients often try and do is increase the back pressure in the airway. And what they do is they sometimes purse the lips and they kind of blow out through pursed lips. Now what this will do is this will increase the back pressure in the airways, and the back pressure will keep the bronchial passages open, because remember the bronchial passages were collapsed, and this sometimes allows these patients to breathe out more efficiently. So the increased respiratory effort means that the levels of oxygen and carbon dioxide in the lungs can be maintained. Therefore, the levels of oxygen and carbon dioxide in the blood can be maintained. These patients do not retain carbon dioxide. They do not become chronically hypercarbic. Therefore, they preserve their hypercarbic medullary respiratory drive, which of course is good. And also, because they can maintain the amount of oxygen in their lungs, they don't get the reflex vasoconstriction that patients do with chronic bronchitis, so they don't get pulmonary heart disease. But because the lungs are hyperinflated, it can actually alter the shape of the chest. Now, a normal chest is going to be broader than it is deep, but because the lungs are chronically hyperinflated, the chests become deeper, and these patients get a rounded, so-called barrel-shaped chest. Now, the problem is in the real world, patients with chronic obstructive pulmonary disease can actually present features of emphysema and chronic bronchitis. So you might get a patient that's fairly pure chronic bronchitic, and you might get a patient that's a fairly pure emphysematous patient, but very often they're a bit mixed up and you get features of both in an individual patient. But these are the basic two clinical presentations, the bronchitic presentation and the emphysematous presentation. So let's go on now and think a bit more about the management in COPD. Well, the first thing to say is we want to eliminate pulmonary irritants. If these patients are smoking, we should certainly encourage them to stop. And we need to make good observations of them, the level of dyspnea, the level of cyanosis. And if there is reduced amounts of oxygen going to the brain, is this affecting their mental state? So observations of dyspnea, cyanosis, mental state all give useful indications about how the patient is getting on. We want to make sure that these patients get their influenza vaccine, because if not, they can get viral infections, and this predisposes to bacterial infections and can make the patients very ill. And then it's always important to observe the sputum. What is the volume of the sputum? Is the volume of the sputum changing? If there's increase in volumes of sputum, that might indicate that the infection is getting worse. And what colour is the sputum? For example, green sputum indicates that the sputum has been stagnant in the respiratory passages for a long period of time. Yellow purulent sputum might indicate bacterial infection. Rust-coloured sputum can indicate pneumonia. So what colour is the sputum? How much sputum is there, and how is the trend changing? Then, of course, basic observations are important: TPR, BP and SpO2. So T stands for temperature, and if the patient is developing an infection, they might be becoming pyrexial. The temperature might start to go up. And if the pulse is high, this could indicate hypoxia, because hypoxia can induce a tachycardia. And what about the respiratory rates? Well, we know the respiratory rate increase with exercise in chronic bronchitis, and we know that the respiratory rate can be increased most of the time as an emphysematous patient puffs to try and compensate. That is, they have an increased respiratory effort, because remember, these patients can be pink and puffing. The blood pressure can go up. Again, that can be an indicator of hypoxia, because hypoxia is going to stimulate the sympathetic nervous system. Now, SpO2, S stands for saturation, P stands for peripheral, so it's what is the saturation of oxygen in the peripheral blood. And we know that in chronic bronchitis this is likely to be low. Some patients with chronic bronchitis are chronically hypoxic, so have chronically low oxygen saturations. And if there's an exacerbation of the condition caused by infection, then the oxygen saturations might also go down acutely as well. But we know in the more emphysematous patient that the oxygen saturations are likely to be preserved. And sometimes we talk about type 1 and type 2 respiratory failure. Now, type 1 respiratory failure can describe hypoxia but without carbon dioxide retention. And in these patients, when we give them oxygen therapy, we want to be aiming for saturations of 94 to 98%. But in type 2 respiratory failure, these patients can retain carbon dioxide. And in this case, we probably want to be aiming for oxygen saturations of 88 to 92%. We can tolerate lower levels of oxygen saturation in patients that are chronic carbon dioxide retainers. In COPD patients, generally speaking, we want to avoid things that put them to sleep and sedatives, because if the patient's asleep, they're probably going to be lying down, and that can impair their ventilatory efforts. So usually these patients should be nursed sitting up, propped up with pillows, because people breathe much better sitting up than they do lying down. The diaphragm and respiratory muscles work more effectively. And when someone's sitting up, the bronchial passages also tend to dilate, so patients should be nursed sitting up. We want to encourage expectoration to get rid of as much of this nasty sputum as possible. And we also want to encourage deep breathing. That's going to improve the amount of gases getting to the alveoli, and also deep breathing can also encourage expectoration, which is good. We want to keep the secretions moist and liquid, so we want to avoid dehydration. If a patient's dehydrated, the sputum will become even thicker and more viscous than normal, whereas if we keep the patient hydrated, keep the mucus as thin as possible, it can be cleared by the mucociliary clearance system more effectively. And there's all sorts of physiotherapy techniques that can be used, like postural drainage and percussion to loosen up the sputum. And we also want to make sure the patient's always got something to spit into. We want to keep a close eye on these patients to make sure they're not getting infections, and if they are developing infections, we might want to consider giving them antibiotics at an early stage. If there is a change in the sputum, we can send sputum off for culture and sensitivity. If we send some of the infected sputum off, the microbiologists can tell us what bacteria are growing there and to which antibiotics those bacteria will be sensitive. So we can give the right antibiotics for the particular infection that the patient is suffering from at the time. We also want to avoid cross-infection. So we want to avoid giving these patients viral infections or other bacterial infections. And indeed, if the patient's infectious, we don't want to put them next to an immunocompromised patient, because they could give their bugs to the patient next door as well. We want to pay attention to the normal activities of daily living, of course, and particularly mouth care. Nutrition is important in all diseases. We want to make sure these patients have an adequate balanced diet, but we certainly don't want them to become obese. So we often give them regular small meals, because a regular small meal will reduce pressure on the diaphragm as well. If there's a lot of food in the stomach, if a large meal is eaten, then it's harder for the diaphragm to go down during the process of inspiration, and this can reduce respiratory or ventilatory efficiency. So regular small meals are a good idea. And when the patient's feeling okay, get them doing some exercise, keep them as fit as possible. We give these patients psychological support, of course, because not being able to breathe is really quite distressing. We can give them bronchodilators, inhaled puffers or nebulizers. Some patients, especially if there's an asthmatic component, we can give them prednisolone, maybe 30 milligrams a day for a couple of weeks to get them over an acute exacerbation. And after that, some patients will benefit from being maintained on inhaled corticosteroids. The advantage of giving inhaled corticosteroids is there is a lower systemic dose, so we don't get the disadvantages of steroid therapy, the side effects of steroid therapy, but hopefully we get the benefit of the corticosteroids where we actually want it in the airways. And if patients are very edematous, they might require diuretics to increase urine output. And we've already mentioned on the first podcast that these patients can benefit from long-term oxygen therapy at home. So plenty of interest, plenty to keep you going with these patients, and we see plenty of them. Unfortunately, we are not short of chronic obstructive pulmonary disease. Obstructive pulmonary disease.